We're going to specifically talk about pelvic organ prolapse and looking at patient satisfaction and success. So here are my disclosures. We're going to review definitions of success in prolapse. We're going to discuss addressing patients' needs. We're going to review various surgical approaches and review the literature on outcomes. So there are 4 treatment options for prolapse. There's conservative management, pelvic floor physical therapy. This doesn't address their anatomy per se, but it makes them feel better by strengthening the pelvic floor. Pessary, which is a good non-surgical option, and surgery. We're going to focus on surgery today. So considerations. You have to consider the severity of the prolapse, the prolapse-specific symptoms, and their level of bother. And as Dr. Kobashi was saying, these often don't correlate. You'll have women with high-grade prolapse, it's basically all coming out, and they say, I'm not really bothered, can I just leave it alone? Or you'll have patients with very minimal prolapse, super bothered, and they have all these symptoms. You have to think about their general health and activity level. I have patients who are like UPS drivers and lifting heavy things, and we have to take that into consideration about when we consider their repair. Think about the goals of the patient and educating them on prolapse. This is very key for their satisfaction because there are often a lot of misinformation and misunderstandings about prolapse. For example, some of them think that if you fix the prolapse, their recurrent UTIs are going to go away, and you have to tease that apart and put that into separate buckets. A thorough informed consent process is important. Surgeon preference and capabilities is a big driving factor, as not all surgeons do robotic surgery or vaginal reconstruction, etc. We also have to manage their expectations and let them know that, for example, their anatomy may be not perfect as far as grade 0, but if they're feeling better, that's really the goal, and if their symptoms are relieved. So there's various surgical approaches, and in some broad categories, I would say are reconstructive versus obliterative. Reconstructive means you're going to re-support the vaginal canal and all the compartments, as opposed to obliterative, where you're going to really close things up and not reconstruct. There's a vaginal approach, an abdominal approach, and if it's abdominal, it's going to be open, laparoscopic, or robotic. Repairs can either be native tissue or augmented with graft. So we have to think about multi-compartment prolapse versus single compartment. On exam, it might be a high-grade rectocele, but everything else is in position, or it might be everything, the anterior wall, the uterus, and the posterior wall. And they're actually kind of fighting for who's going to, get out the leading edge. We'll talk more about the importance of apical support, as this is a big push in our field. Consider concurrent anti-incontinence procedure and whether that's needed, specifically for stress incontinence. You have to know whether this is going to be a primary pair and what decisions are for there versus a recurrent prolapse, as well as patient factors, tobacco use, uncontrolled diabetes, obesity, pelvic pain, dyspareunia, pelvic floor dysfunction, bowel dysfunction, sexual activity, and any conditions that increase abdominal pressure. So prolapse is a multidimensional process, and success is difficult to define. So historically, most of the studies in the past have really much focused on anatomic success without really considering patient symptoms and satisfaction, and that, as Dr. Kobashi was saying, has led to a lot of lack of standardization in our field result to the estimates of success. So this is the E-CARE trial, the extended CARE trial. This was a secondary analysis of the CARE trial done by Matt Barber and the Pelvic Floor Disorders Network. They defined success in 18 different ways. They sliced it and diced it for anatomic and symptomatic and strict criteria and less criteria. And you could toggle this, again, any which way. Success was as low as 19% or 97% based on the definition used, same data set. But what was great about their study is they actually asked patients what mattered to them and what they perceived as improvement and treatment success. So it turned out that the definitions that included the absence of vaginal bulge symptoms had the strongest relationship with patients' assessment of overall improvement and success. The anatomic criteria alone did not have such a relationship. So moving forward, they recommended that definitions of success after prolapse surgery should include the absence of a vaginal bulge symptom, anatomic criteria, and the absence of retreatment. It turns out the hymen is sort of the threshold for which women feel symptomatic or not symptomatic. So if their prolapse is about at the opening, they start to feel symptomatic. If it's beyond, again, it's more symptomatic for them. If it's within the hymen, they generally are not symptomatic. So this is important for counseling them as well as to what the goal of surgery is. You can say, if we do surgery, our goal is to relieve that vaginal bulge symptom that you're feeling, and that can be a concrete goal to achieve. So how are we meeting patients' needs? This is a study I did with Jennifer Enger at Cedars-Sinai. We actually assessed all the patients in clinic for their health literacy with an assessment tool, and then we recorded their clinic visits and their diagnoses and treatment options. We then interviewed them after their clinic visits on their understanding of the visit and their understanding of their diagnosis and treatment plan. Even in the women with high health literacy, which they all very much had high health literacy, they did not have a very good understanding of their disease and treatment plan. And of the treatment of their diagnoses, prolapse had the least understanding. And so they understood incontinence pretty well, but prolapse was a confusing topic for them. And so certainly it means that we need to address this head on and help bridge that gap. This was another study that our group has done, and we looked at a popular website called Reddit. And this is a forum where people go on and they chat about all kinds of topics. And there was a subreddit for postpartum women, and we searched for all the threads on prolapse, pelvic prolapse. And so the themes that we got out of that were that many women were unaware that prolapse could occur postpartum, and they were very frustrated by that lack of discussion. They expressed a need for more supportive and immediate comprehensive care. They sort of felt that their providers were brushing them off and felt sort of like validated when they finally got into pelvic floor physical therapy. The symptoms of prolapse, they really talked about sort of the disability on their life and how it had affected their daily lives. So from this, we had 3 emergent concepts: that it is a difficult, debilitating condition, both mentally and physically for them. They were self-driven to seek out help, and they were motivated to help others understand this condition. So interestingly, we're taught that prolapse is benign and it's not painful, but the patients sort of had a different perspective. And so we can learn directly from their reported experiences and therefore better, hopefully, meet their needs in the future. So now we're going to talk about prolapse surgery outcomes and start with the anterior compartment. As this is the most frequent site of prolapse, the top line is cystocele, development of cystocele over time, and actually over age, from 55 to 85. The middle line is rectocele, and the bottom line is uterine prolapse. So this is their lifetime prevalence of prolapse in this compartment. The picture on the left is a vaginal exam, and then the next 2 pictures are an MRI sagittal view of this same person with prolapse. And so as you can see, this person has a high-grade cystocele, and it's often associated with a loss of apical support. The apex, the top of the vagina, comes down halfway or more in the vagina and contributes to that high-grade anterior wall prolapse. So the rates of reoperation after prolapse surgery vary widely in the literature. There was sort of a landmark article by Olson et al. In 1997, and they reported a lifetime reoperation rate of 29%. But when you dig into that data, it actually is grouped together, prolapse and incontinence, and it doesn't distinguish what compartment the prolapse is, and so if they had a reoperation, was it the same department or different? So then when you look at site-specific recurrence and site-specific reoperation, the reoperation rates are more like 3 to 10%, so more reasonable. But that fueled the perception that native tissue repairs don't work, but that's not supported by the data, and it propelled the use of transvaginal mesh. And transvaginal mesh does have, particularly better anatomic results, but at the cost of increased mesh complications. So this was the study that Dr. Kobashi and I did, looking at contemporary definitions for success in prolapse surgery. We applied this to 12 randomized clinical trials that compared mesh to native tissue repair in the anterior compartment specifically. And we showed that native tissue repair actually does have excellent symptomatic success rates, 62 to 100%. And reoperation rates were low, so 5% in native tissue and 9% for mesh. So moving on to the posterior compartment, this is, again, on the left is a high-grade rectocele, and then the following 2 are the MRI sagittal views with the organs outlined in the last one. So that's a defect and a bulge in the posterior vaginal wall in the compartment between the rectum and the vagina. Based on that exam, you might not know if that's a rectocele or cystocele. So on exam, you have to isolate the compartment. We use a plastic speculum and isolate the anterior wall, just look at the posterior wall, isolate the anterior wall, just look at the posterior wall. you'll often get referrals for people they have a cystocele, it turns out it's a rectocele or vice versa. The most common symptoms are stool trapping, straining, splinting, vaginal bulge, feeling of a lack of support. So traditional posterior compartments have a high anatomic success rate. There is a rate of postoperative dyspareunia that women should be aware about. As far as defecatory dysfunction, they often have an improvement in their bowel symptoms that are specific to the rectocele repair, improved in about 2/3. If they have a longer history of splinting, they're less likely to resolve that persistent splinting postoperatively, but certainly the goal would be to have relieved that surgically. I do like to counsel patients that their functional bowel disorders, their lifelong constipation, will not be solved by a rectocele repair and other upstream effects. I sort of tell them it's like a patch job right there. It's going to make that stronger and less bulgy, but it's not going to treat all your bowel symptoms. So moving on to the apical compartment. The loss of apical support is present with high-grade prolapse. And therefore, the support of the apex is essential for a durable surgical repair. The best correction of the anterior posterior wall may fail if the apex is not supported, and apical repairs do have good success rates. So this was a Medicare analysis by Jennifer Enger's group that looked 10 years after prolapse surgery. Your reoperation rate is going to be higher if there's a cystocele only versus a cystocele plus an apical procedure. So that just supports that theory that the apical repair is important. So here we have a picture of an apical prolapse. Everything's out, and that's the leading edge is the sort of, I call it like the inside-out sock. And then if you look at the MRI view, you've got the MRI sagittal view. It's an enterocele. There's small bowel falling into that. So you've got multiple approaches. You've got vaginal approaches and abdominal approaches. You've either got the sacrospinous ligament suspension and the uterosacral ligament suspension. These are probably the two most popular vaginal suspensions. And the abdominal, which would be the abdominal sacral colpopexy. So as far as vaginal procedures, the sacrospinous ligament fixation suspends the top of the vagina to this ligament between the ischial spine and the sacrum. This is done with sutures and can be done unilaterally or bilaterally. This is from the Roz Atlas, and it shows the sort of critical structures that surround this. So you can't be too cranial, because then you've got the nerves and vessels. You can't be too lateral, because you've got the ureter. You can't be too medial, because you've got the rectum. So that little blue dot on there is sort of the target. You've got about a 1 centimeter point to which to place the sutures durably and safely. And we spend a lot of time in our fellowship teaching our fellows to do this procedure safely and durably, because that is important for the longevity and durability of the repair. So the advantages is it is a vaginal approach. Success rates are good in multiple studies. Disadvantages, some people think it deviates the axis of the vagina, because you may do a right sacrospinous fixation and leave the rectum alone. There's a risk to injury to nerves, vessels, and there is a transient buttock pain that can be associated with that. I tend to see that when the sutures are a little more aggressive. The vaginal uterosacral ligament suspension is also very popular and well utilized. Sutures are placed, the uterosacral ligaments, you can often see them vaginally, robotically, and after post-hysterectomy vaginally. Sutures are placed in the ligament after they've been grabbed with an instrument and then pass through the vaginal cuff. The uterosacral ligaments is sort of a fan of tissue, and it runs right alongside the ureter, so they are at high risk for ureteral injury. Again, advantages, it is vaginal. You often are staring right at them after intraperitoneal access after a transvaginal hysterectomy. It restores the normal anatomic axis of the vagina, this sort of banana shape. Both of the vaginal approaches do. Success rates are good. The main thing is the high index of suspicion for ureteral obstruction or kinking. So cystoscopy is important for both of these procedures. There's been a randomized clinical trial called the Optimal trial that looked at the difference between these two, and essentially there was no difference in the composite outcomes or serious adverse events. So moving on to the abdominal sacral colpopexy. This is when graft material is attached to the apex of the vagina and suspended to the anterior longitudinal ligament of the sacrum. This is considered a gold standard, durable procedure for prolapse. It is compensatory in that it's not in the exact location where it was originally, but patients feel really well when the apex is supported. There are many techniques, but the principles are very similar. So advantages, it has been shown to have less apical failure, less postoperative dyspareunia, and less stress incontinence. Success rates are very high. Disadvantages would be abdominal access is required, and therefore all the potential complications associated with abdominal access are potential. Small bowel obstruction, hemorrhage, and it does have a higher cost than vaginal surgery. It should be noted that graft erosion is also, certainly using a synthetic material, and graft erosion is as high as 10%. So this is the extended care trial where they looked at long-term outcomes for abdominal colpopexy. They looked at 7-year follow-up and a composite outcome. And at 5 years, 1/3 of the patients met criteria for failure and 5% needed retreatment. So these are the Kaplan-Meier curves. On the left is anatomic success, and on the right is symptomatic success. And of note, this was clinical trial data, but mesh erosion rate was 10%. So that's certainly something to follow, and that's something we see. We see mesh erosions in the bladder, in the bowel, and particularly at the apex of the vagina is when you see. So colpopexy versus a vaginal suspension, reoperation rates are low for both. It should be noted that minimally invasive does not necessarily mean minimal risk, as there are cardiopulmonary and bowel complications. Patient selection is very important, patient counseling very important, and a quality procedure is really the right patient, the right procedure at the right time. Some comments on uterine prolapse. Pelvic organ prolapse is the indication for 14% of hysterectomies performed in the US. 300,000 surgeries are performed annually, and most of them are vaginal and some are abdominal. This is a skill we're teaching in the urology-based FPMRS programs. And why? Why hysterectomy? It enables access for a safe and durable apical repair. Excellent long-term outcomes using clinical meaning definitions, reliable anatomic outcomes, because again, you can do that apical support. And also you have the opportunity to do a prophylactic salpingectomy, which is now becoming standard of care in gynecology because it decreases their risk of ovarian cancer. There are ablative procedures, particularly the colpoclysis, or if a uterus is present, a Lafort colpoclysis, and this is specifically for women with high-grade prolapse. Everything's out, and they do not desire future sexual activity. Success rates are high, low rate of complications, low rate of regret, high satisfaction. This is a probably underutilized surgery that could be utilized more. Here's a surgical picture. You essentially denude the vaginal epithelium, place purse string sutures, and invert it, and kind of close up the vaginal area. So key points. Definitions of success in prolapse surgery are variable, and so keep that in mind. Patient satisfaction is most correlated with the symptomatic relief of vaginal bulge. The hymen is the threshold for vaginal bulge symptoms, and an apical repair is correlated with durability. For goals of treatment, we're trying to relieve their symptoms, restore their anatomy and their function, avoid complications, and improve their quality of life. Thank you.